This webinar topic today follows our Kentucky SOS metric number 8, which reads, the organization collaborates with community partners like clinics, home-based care, pharmacies, law enforcement, religious organizations, and governmental agencies to promote appropriate use of opioids within the community. And I'm delighted to say that Clark Regional Medical Center is an excellent example of this collaboration with our community partners. We are grateful for Ms. Barbara Kinder's leadership on the SOS Advisory Committee. And today I have the honor of introducing to you 3 nurses, Rebecca Cox, Teresa Daniels, and Ashley Moore, and pharmacist Elizabeth Lovell. Kentucky SOS welcomes Clark Regional Medical Center in their presentation, Community Partnerships Combating the Opioid Crisis. Clark Regional.
Hello, Emily. Thank you. We're very happy to be here. So this is information regarding the presenters, the disclosure of conflict and interest. All above named presenters have no real or apparent financial interest to disclose. Our objectives today are to help everyone understand the role of community partnership with substance use disorder interventions, illustrate treatment options for emergency room and inpatient medication-assisted therapy, MAT, recognize the importance of provider champion advocating for those with substance use disorder, and also to identify community resources for overdose. So I'd just like to start with our why. And I go back, and I don't know if I said, but this is Teresa. I guess thinking about why the Director of Infection Prevention is involved in opioid stewardship and things. Initially, I started out at Clark Regional Medical Center in the emergency department from 2005 to 2010. During that time in the emergency department, I can remember patients coming in, and one in particular gentleman that stood out to me, he was in withdrawal, and he was a young gentleman, and he said, please give me help, I need help. And we could medicate him, but we really didn't have anything in place to assist him with referrals, resources. And honestly, looking back, we just had something to help him, but with the current withdrawal symptoms, that we didn't have any formal process in place to get him the treatment he needed. And that was seen time and time again. So we had no policy in place. We had no resources. We had no stewardship. Our community overdose numbers were on the rise, and the stigma that comes along with the substance use disorder population, we wanted to help reduce that stigma, along with staff resilience, because time and time again, when they're seeing the overdoses and that helplessness that caregivers and frontline staff feel from that burnout of seeing it over and over. So we just felt that it was time for a change. In 2016, we teamed up with our local health department in looking at the needle exchange program, which opened up that conversation. We community partnered with the mayor, EMS, the police department, other areas throughout the community, and we had a formal community meeting at our hospital. We also had our GI specialist, who at that time we were taking care of seeing the hepatitis population or the numbers increase. So that's when 2016, our community did come together, and we adopted the needle exchange program, along with opening up the conversation of the substance use that we had in our community. Along in 2016, we then became members of the Clark County Agency for Substance Abuse Policy, which is our ASAP. That is volunteer members from our hospital currently I'm one of the board members of that, and we just more or less go through what type of support that we can give one another in our agencies, as well as what type of initiatives that we can implement within our community. Recognizing those community programs and then pushing out that information. So within that ASAP meeting, you will have Achieving Recovery Together, you will have Celebrating Recovery, Spark Ministries, which is actually out of Powell County, but we service Powell County, so they come to that meeting. We have a magistrate, along with other programs throughout the community, to discuss types of programs that they're implementing to help combat the opiate crisis.
In the emergency department specifically, we identified a need to help expedite the care of mental health patients. The least safest place research shows for mental health patients to be is actually in an emergency department. They need to get to a definitive care location. So we did look closely with our partners, Bourbon Community Hospital and the Ridge, at multiple different avenues to evaluate these patients. We started out with bedside evaluations, which you guys can imagine there were some timely delays in that, just from giving them the brief on the phone and waiting for them to arrive to your facility. They had on-call groups and they came as quickly as they could, but that was something that was a little bit of a delay to get them into the hospital, to the bedside. We did want our partners to be our qualified medical providers and allow the emergency room physicians to work with them as a partnership, instead of the emergency department physicians independently operating with this care. They felt more supported in the decisions and said that the emergency room, of all the specialty places, was not the place that they felt like that was their expertise, behavioral health. So as we were looking through our processes and breaking them down, we kind of did a mini lean project, and what it came down to was we identified that the majority of behavioral health referrals had a key component with substance use disorder. This and made them a population that was even more vulnerable in our facility. So we did come up with several internal policies to protect patients, having sitters nearby and the appropriate medication regimen from the beginning. This is for patients who are actively in withdrawal or having symptoms that they needed to have care for. So when we got to partner with Achieving Recovery Together, we were really excited because this process allowed for peer support specialists who could speak to the patients at their level and who had been there before to be their support person at the bedside with them. We had never seen anything like this before. You could compare it to the rape advocacy line. That is actually something that we legally have to do when somebody comes in for a sexual assault case. So this is something that we just basically said we have to at least offer this to all of our patients. So our CEO at the time pulled our team together with some of our community partners and the ART program, Achieving Recovery Together, and they were hungry to get in this building. They wanted to get in here and help the patients and do great things. So when we worked together, administrative team and legal team decided that we did have to get a consent for care. So as you'll see, we came up with a patient agreement, and we would disclose to the patients that we were going to release their medical information, if they were okay with that, to a partner company. And we did find some immediate limitations. We had came up with scripting, and we wanted them to feel very supported and know that what we were doing was in their best interest. But there is a lot of anxiety and stress around this entire process for the patient, their family members, everybody that's really involved. It's a high-stress environment. So the ART program, one of the concerns we took to them was, we are worried that before you even get here, the patients are going to leave, even if they consent for care. And they said, don't worry, we'll be there in no time. And I'm telling you, in 5 to 10 minutes, people from our local community are at the bedside
probably faster than we could get somebody within the building. They have a drive to help these people. So our peer support specialists, after we get our consent completed, do come to the bedside. They do sit down with the patient and the family. They tell them, you know, we're here for you. We understand. We'll do anything it takes to get you where you need to be on your road to recovery. And when the patient agreed to sign that consent, they only agreed for us to release information and to allow Art to come in and talk to them. So at any time they say, I don't want to do this anymore, or, you know, this isn't the path I want to take, the Art team leaves them some educational material, and then they'll follow up with them later on at a different time when maybe the people may be a little bit more prepared. The patient agreement also allowed us to, the compact with the patients that they felt like, the ones that were ready felt like we were giving them everything we could to help them get along in their road to recovery. So as we were working with the ART program, we decided to focus on some of the policies in the emergency department through our ED council. We looked at ED opioid stewardship internally and implemented emergency room policy that requires our medical director, Bruce Kostelnik, to review dispensing and prescribing practices in the emergency department at our monthly meeting. So he looks at the practices of the peers amongst themselves, if there's any outliers, or if there's any prescribing changes. He'll sit down with the providers and look at records to ensure that we are dispensing and prescribing appropriately for the proper diagnosis. There's lots of guidance around opioid stewardship in the emergency room. It's actually on the several best practice. Emergency Nurses Association has a lot of guidance, and we use that along with our parent company to make sure that we met the needs of that. Our medical director is very dedicated to this cause, and if he wasn't, I don't think we would have been as successful as we were, and we still are. He has said, you know, you got to be a part of the solution, not a part of the problem. He said that he received some education in one of his trainings. If you're not helping this cause at this point, you're hurting it. This is something that we couldn't turn, away from. It was time for us to really make some changes in our department. So as we monitor prescribing, you can imagine that at first we had some upset patients. They came there for narcotics or whatever medication they felt like they needed. And we did have a decline in volume. And then we had an increase in volume of patients who actually were not there for pain medication, which was interesting. But the emergency department is known as one that does not prescribe and dispense. So we do not have a lobby full of patients that are actively seeking, which is very motivating to our emergency department staff, and they feel like they're really making a difference as well in another way. So as the ART program was working with us on implementing care at the bedside, they came to me and said, a couple of your nurses seem to be the ones who primarily call us. They can get us a referral on almost anybody. What are they doing differently than anyone else? And this was two of my charge nurses, Donald and Tiffany. And I went and talked to them and asked them, what are you doing? And they said, well, we personally feel like it takes time. We have to sit down in the room and explain to people what the program means, use all of the tools we have, use our scripting, like make the consent a positive. And they said they have personal experiences with addiction within their family. And that's when we decided to use them as the avenue for the communications with the patients primarily. So if a patient's at the bedside and they're there actively seeking, or they're there with maybe an infected injection site or something that we would say, do you need help? We will have our provider and nurse champions be the ones to go to the bedside and communicate with them. Their communication is just better. It has allowed us to reach out to a lot more patients, and a lot more people have been agreeable to allow Art to come in and work with them. We're really proud of the work they've done in the department, and we do want to be a part of the solution and in all of this with our community partners.
So, as Ashley mentioned, having a physician champion was huge in getting this process up and going. So when pharmacy kind of was engaged in helping these patients, the first thing we looked at was medication-assisted therapy. So it's for any drug of abuse, whether legal or illegal. So the first thing I did was really kind of research what is out there, what is the best place to find the information and how to best treat these patients. So I reached out to Art for some help because there's not lots of great information, particularly when it comes to the illegal narcotics of abuse. So that was kind of the first thing. The best we could kind of come up with, when you'll see the order set in a minute, is really just symptom management, just really helping these patients through the withdrawal. The next thing we looked at was the legal standards. What could the physicians prescribe and not prescribe, particularly when it came to Suboxone, as there's lots of information and restrictions around that, and what was required for a DEA-X license and what would not be required for a DEA-X license. Then we went to the order set development. That was really in conjunction with Ashley and her staff, as well as the medical director and Art, to see what is it would best suit these patients, how would it work best on the ER side, and then how can we, after building it for the ER, how can we best build that for the inpatient if we ever have to admit these patients. The other thing was really having some nurse education when it came to the COW scale, so the clinical opioid withdrawal scale. How can we have standardization within our nursing staff so we can make sure to properly medicate these patients' symptoms? So here you can see is the ED order set that was built. And so most of it is automatically pre-checked, so that way it really can help get to the patient in a timely manner. The Suboxone, you can see, is unchecked. That was based on physician guidance, how what the withdrawal was for the patient, how they were experiencing it. And this was all in correlation with Art and getting them in with the patient and making sure that was in conjunction with them.
So this is Rebecca, and when we started the inpatient implementation, the case management team was a valuable resource. Our case management team is made up of nurses and a social worker. And kind of like Elizabeth said and Ashley, we kind of had nurse advocates, champions. A lot of the nurses, the patients would come to ICU, and by the time they would get to inpatient, especially at first, we didn't see a lot of agreement. By the time they get to inpatient, they were upset or they felt better, they wanted to leave. And so as a little bit of time went on and some education, with the case management staff and the physicians, the nurses really started advocating, and the more that the ART program started coming in, and like Ashley said, they are literally here within minutes. If we call them, they say they are on their way. And so our nurses started seeing a difference, and as time went on, the patients really did start to agree to the ART program, and the case management team, kind of like the nurse champions in the ER, would sit down with them, talk to them, and they would agree. Now, sometimes they are a little hesitant. They want to do ART, but they're like, I need to go home, or I want to go home. And one of the other reasons with the consent that we get them to sign, we say, okay, if you are leaving, we'll have them call you or meet you at the house, something like that, and they will agree to that. So they kind of can get out of here, settle down a little bit, and again, as fast as ART would be here, they literally meet them at their house. Sometimes when they won't let ART come to speak to them, or even if they do and they decide that's not exactly the route they want to go, they do let them leave in that resource pack, the ASAP resource pack. Our case management team also keeps those packets on hand, and the ER staff, and if they will not agree to ART, we do give them those resource packets. We try to highlight the specifics kind of a little more tailored to them, but I don't think that it's very rare that we have anyone refuse that. And we also get mental health evaluations with our facility partnership, Bourbon Community Hospital. They're very helpful for us and with ART with these patients, and to help them with the treatment they need if they opt for an inpatient, outpatient, different things like that.
And this is Teresa again. If I can describe the ASAP resource packet, what that contains is it's a booklet that ASAP put together with the meeting times of support groups within our community, the different meeting times, also the counseling available in our community, as say Mountain Comp or comprehensive care centers. It also gives information on MAT therapy on an outpatient. So the resource packet is full of excellent information for those who are wanting to seek recovery.
So this is Elizabeth. So for the inpatient MAT order set, it was very similarly built as the ER in correlation with the med-surg director as well as case management, just so that way we had continuity of care between the ER and the inpatient, as well as helping all the staff, regardless of the unit, how to properly treat these patients. So keeping it standard between the two units was massive in helping implement this properly.
And I think we've touched on this quite a bit so far with the community partnerships. Myself as well as Ashley have discussed the barriers, and Teresa, the perception, the stereotypes. A lot of people didn't want to come in and seek help, or if they did, they just didn't get the help. We didn't have the resources that we needed. So with a lot of education, Elizabeth with the treatment options, the data, the providers getting on board and educating themselves, and the nurses, I think it all started to come together and the community became more aware. And so we did get that patient involvement. I think the ER was a little faster as far as the patient involvement, because they're a little more acutely right in the moment. When they came over to the inpatient side, that's where the barrier of patient involvement became more prevalent, just took a little more time. So as far as the community partnerships and successes, our community involvement, the fundraisers, the hospital employees do fundraisers for ART, and we do a rally recovery here in Winchester. The hospital is present at that rally. Again, the ART partnership, which has been huge, and Ashley was talking about the emergency department taking lead, and Teresa was speaking to the UK Healing Community Study.
Yes, I'm sure a majority of you are familiar with the UK Healing Study. And it's actually the largest research grant received by the University of Kentucky. And it is we received this for Kentucky because of our high opioid abuse and overdose deaths. 16 counties received, or 16 counties in Kentucky are actually a part of this research study. And what we focus on during this study is overdose education, medication for opioid use disorder, and prescription opioid safety. So this started the fourth quarter of 2019. We actually have a hospital, our hospital actually co-chairs for the MAUD committee, which would be myself and Dr. Sloop. The community's gap discussed in the committee session. So we have the three groups discussed previously, and with that, we're looking at what gaps are in the community and how we can perform interventions with the grant to reduce those gaps, to remove the gaps. The gaps found were the referral, transportation, follow-up care, and the absence of mild therapy within our community. So the hospital participation, what we did was we hosted a medication for opioid use disorder waiver training in September. We also, the MAUD awareness, it focused on rising awareness among community members, healthcare providers, and persons lived experience and encouraged medication treatment for opioid use disorder. Pulled out of the MAUD in inpatient initiation from the study. So when we were in the group, Dr. Sloop and I were listening to it, and we realized, and during our discussions, we realized that we would have individuals come into the hospital and they would be positive for, say, Suboxone or buprenorphine. And that stereotypical, well, they're taking buprenorphine and we weren't really doing anything for that. So with looking at that and that gap and looking at the patient, we're thinking, well, if you're going to take buprenorphine, you're not really getting a high off of buprenorphine. So that's, and if you're buying it off the street, that's a cry for help. So we recognized the commitment of Clark Regional and administration, and we decided we don't need to put that in the UK healing study, that Dr. Sloop and I could take that on, and we would work with our administration at Clark to focus on getting that MAUD inpatient initiation so the research study could put their resources towards a different intervention or goal and let us take that on. So we began that work. And actually, in the picture, that is Dr. Sloop, and he's actually sitting and speaking with Amber, and Amber's with Achieving Recovery together. So we have that wonderful partnership there. The focus on the MAUD, we looked at it, and with the IDT is an interdisciplinary team meeting that occurs daily. And what we do there is we advocate for patients with substance abuse disorder and other things. I mean, we're talking about congestive heart failure and surgeries and things like that. But when we trying to break that stigma, trying to assist in getting those individuals help, we wanted to develop some sort of a referral system for patients with the buprenorphine. The self-medicating, we wanted to develop an order set, getting the consent to ART, and the therapy initiation. And that's where it took that Dr. Sloop, where he has the X license, where he can initiate it if needed, because we can continue, and I believe, and Elizabeth can chime in, I do believe that you can continue Suboxone, but you cannot initiate it without that license. Correct, Elizabeth? Is that correct, Spencer? Yeah. Okay. So, so we want to have a safety net for that. So we wanted that referral system for Dr. Sloop. Let's see. Therapy initiation.
Sorry, Trace, I didn't realize I was on mute. That is correct. As long as they have a valid script, the inpatient provider can continue the Suboxone, but they just cannot start it without that DEAX license.
Okay, perfect. So yes, and I hate to try to speak for a pharmacist, so thank you so much. So with doing that, and we were able to initiate a new order set, so we're really proud about that. So we have patients that have come into the hospital. We're noticing that they're starting to withdraw, and we still ask that question, well, are we using the order set for, it's called substance use disorder order set, where it will medicate or assist that individual. And I guess I'm not going to steal Elizabeth's thunder, so I can go on. So what we inserted into the order set was the buprenorphine and the referral to Dr. Sloop.
That was a really big win for our group as well, because we did think that we had more stigma in the inpatient areas. And with Dr. Sloop's support and providing a champion, he was able to educate a lot of our inpatient physicians and providers and explain how he could support them. The same as Art supports us in the emergency department, and inpatient, but it was very similar. Dr. Sloop really explained a lot of things and said, I can do a lot of this, just let's support the patients. And so I think that took a wall down for us.
And actually what we're finding now are the hospitalists are reaching out, and they're using that order set and not reaching out so much for Dr. Sloop. So it's somewhat changing the way that we're treating the individuals, and it's really great. As Rebecca was talking about, individuals would leave. Well, when we kind of debriefed on that, we're like, well, are they withdrawing? They're withdrawing really bad, and are we not recognizing that? So with this order set and understanding that they had a positive urine drug screen, that we could actually get them the help that they needed at that time.
I also think, this is Barbara, I also think that one of the things that we saw happen in our interdisciplinary team meetings each day was that more and more of the people that attended the meeting became comfortable with speaking up. So if myself, Rebecca, Teresa forgot to say, hey, let's contact Art, we would see other pockets of folks, nutrition services or respiratory, that would speak up and say, hey, have we gotten Art involved in this particular situation, which I thought was a huge win, because I think people were beginning to recognize that it as an illness, and that we should be treating it just as we do congestive heart failure or the other things that are going on with the patient.
Correct. And one thing that the Healing Partner worked on, and this was pre-COVID and during COVID, was breaking that stigma. So that, and it didn't come out as well as I would like it to, but it had the ads where I take buprenorphine, or I'm a part, like this one, I'm a parent, a partner, and a leader. I also took methadone to support my recovery. And in driving in, it's okay if someone takes buprenorphine. It's okay that this is a disease, and you're potentially going to see patients that's coming in with this. And that was just one of the community campaigns that were implemented. One thing that we discussed, and interventions plateau, and you may be still trying to change the way that people view substance use disorder, trying to change the vocabulary and things, but looking at one intervention that I feel that was successful in looking at this chart right here. And we had this great data that came through ASAP, that there were 52 referrals for ART, and 33 of those entered into recovery. And then looking at 2020, which I think the numbers would have been better without the pandemic, but 75 referrals and 45, and I believe this would be ED and inpatient collective. And looking at it, 45 entered treatment. So you'll get into this stagnation where, okay, I have 2 people in the ICU today who are on a ventilator, and there are 3 people on the floor who have substance use disorder. One may have an endocarditis with an abscess, one might be in renal failure, and it just gets tiresome. It gets tiresome. And just giving that, I would suggest sharing this information, because when this is shared with our hospitalists or our providers, and they see that we are making a difference, that people are entering recovery, and it's just not the sadness that comes along with this disease, it kind of perks them up a little bit. So, go ahead.
This is Rebecca again, and we present these numbers when we get them. Teresa usually gets them, brings them to our IDT, and like Barb said, you know, lab speaks up, respiratory, everybody speaks up, and this is such a huge win, you know, not only for the patients and families, but for our staff to continue to be champions. And one of the things that we would kind of encounter is patients or families will, okay, they have finally agreed, they can't make it to wherever they're going to be going for treatment, they don't have transportation, it's too far, you know, everybody else has to work, and ART helps to arrange that. They will come and pick them up, they will take them to their house. It is just such a huge win, and we do have patients or families come back in or call us and tell us, listen, you guys, and they went above and beyond, they drove us there, they said it was going to be okay. It's just such a huge success in all that they do.
And it's that partnership. Like Ashley said earlier, they could not wait to get into this building, because with every overdose, and I'll let Ashley speak to it, ART is called to speak to them. So they are getting into this building with the, you know, with the approval of the patient, of course. But go ahead, Ashley.
So community success was the most exciting part whenever the ART program would designate a member to attend our monthly ED committee meetings. It's usually Amber would come to the meeting, and Amber would come in at the beginning and she would disclose the information from the previous month, and she would let the ED providers know and the staff that's in there the same information specifically for us. So she would let us know who went into short-term and long-term care, what they're doing now, how often she sees them. They communicate with these individuals daily. It's their mission to really help support patients that are joining recovery. They want to be that person. So it is very promising, and it does make people feel like a very hard, maybe we didn't feel like there were any solutions previously. We're starting to really, we have been really seeing great outcomes since we began working the program as a team.
Correct.
We also have Bourbon Community Hospital as our sister facility that will work with us to do the, once we do the behavioral health evaluation, they will determine if somebody can come over there and go into multiple levels of care, detox, inpatient, outpatient. They support that cause very much, and we really appreciate how much they help us. We welcome people to come to the emergency department that are having any kind of behavioral health issues, and we can have them over to Bourbon Community Hospital in less than 3 hours. That is labs back, provider-to-provider communication, our evaluation complete, the initial behavioral health evaluation. That is really great for quality of care in an emergency department. So we couldn't do that without all of our community partners that do help us through with the program. We wouldn't have as much success without all the pieces.
Along with the success of the MAT through the ED. So we would have patients come in, and if they're willing to sign the agreement, then they can. How does that work? You can have 3?
Yes, we have, you can have 3 orders for Suboxone in the emergency department setting on individual cases, and so we keep a track of that when we need to. That way we're not supporting being somebody's family practice or somebody's Suboxone clinic. But there's lots of ways to protect the physicians in that we could implement if we needed to, if we really felt like somebody needed help. But we try to do 3 days in a row. So if they come in on a Friday and the clinics are closed on Saturday and Sunday, then we have them come in early in the morning on Saturday, usually before the department picks up and gets really busy, and the provider will reevaluate them and they'll have their second dose, and then they can get a 3rd dose on Sunday. And by then, Monday, the Achieving Recovery Together team has already got them an out appointment for Monday, so they can get the actual ongoing prescription. And the change in people that you see when you immediately dispense a medication, you don't really understand how withdrawals impacts them. They can't think, they want to leave, they don't want to be anywhere except for where they can get that feeling that they feel normal again. They can't make good decisions. They can't really tell you if they want to go into recovery, if they want to get help, because at that moment their body physically needs to have some type of medication to help them to make good decisions. So when we did start doing the MAT from the emergency department, some of the physicians threw up red flags, and they were really concerned in the beginning. But once they saw how well it worked and how the patients could communicate with them, and that was just like talking to any of us right here, as soon as they could get them to the point that they could make good decisions, they were really supportive of that.
So we're looking right now into the future, and what we're still working on this, we're still combating this. And one thing I do want to say, I put this on the slide, it's words. Words are important. If you want to care for something, you will call it a flower. If you want to kill something, you call it a weed. So we started this prior to COVID, and then COVID came, and we were all inundated with COVID. But that is something we're really going to be focusing on, even resuming that house-wide. And it's just one of those ways to break the stigma and using keywords at key times in everyday language. And I tried to paste it's called drugabuse.gov is where this is. And it's words that matter, terms to use and avoid when talking to you about addiction. So just a real quick example, instead of using addict, you call it a person with substance use disorder. And this is because person first language. User, you wouldn't want to say that. You would want to say person with opioid use disorder again, or person with opioid addiction. And the change shows that the person has a problem rather than is the problem. And I think that's just really strong. Junkie, you would use patient. Alcoholic, person with alcohol use disorder. And one thing that Emily and I actually were talking on the phone a couple of nights ago, and we were talking about when we had, just the other day, we had a patient in the hospital who was starting to withdraw, and I went to the hospitals and I was like, well, you can use the order set substance use disorder. And he said, oh, well, I use the alcohol withdrawal is on the substance use disorder. He goes, well, I use the alcohol withdrawal also because this patient was a dual. And just what Emily and I were talking about is the alcohol withdrawal, we're so advanced with it because it's been around so long and we're educated on it, it's 2 pages. Whereas with the substance use disorder, we're looking at a 2-page, but it encompasses everything on the order set that Elizabeth had worked on. But it's just showing that advancement, and we're getting there. We're slowly getting there, but we are getting there. One thing, and this is the last thing I'll say, is with Narcan distribution in the emergency department. So as a partnership with UK Healing Study with the Achieving Recovery Together, when they are called now, they can distribute. We're not distributing it, but we can distribute, they can distribute, ART can, the Narcan to the individual in our emergency department. So that's a huge win. We did have to have the risk manager involved with that. She worked in the background. Her name's Tracy Kofer for contact purposes. But she had to work with our office to make sure with the legalities and the contract and exactly how we can do that distribution. But we are doing that now. So that's one thing we're focusing on. So in the future, along with breaking the stigma. So I would thank you all for listening, and if you have any questions, we are ready for questions.
Some questions.
Presentation
Clark
mode is now disabled.
Thank you, Clark Regional Medical Team. We are so thankful for this presentation. This is an excellent example of not only collaboration with your community partners, but also collaboration and engagement and just working together within an organization and within your facility. The various disciplines working together to improve health and care and of our patients with substance use disorder. So the lines are currently open. If you have a question, feel free to unmute yourself and ask over the line, over the telephone line. Also in the chat box, I wanted to highlight a couple of comments that were made, and feel free to also, if you have a question, you can put it in the chat box for the Clark Regional Medical Center team also. But one comment that Dr. Christy Deep mentioned in the chat box during your presentation said, agree, it is so important for to recognize and diagnose opioid use disorder instead of drug seeking behaviors. And then also Dr. Brenzel, who also sits on the advisory committee with Dr. Deep, he said it's such an impressive culture shift across the entire organization. It shows the power of having champions take the lead at the local level. So that's a job well done, Clark Regional Medical Center. And regarding when you presented when words matter, Dr. Brenza also said a big one to avoid is a dirty drug test. And that is so true. Words do matter. They matter to our patients and to their families. So are there any questions at this time for our Clark Regional Medical Center teams? Maybe while you're thinking about questions, Kentucky SOS is always delighted to offer continuing education for our monthly webinars. Again, this month, we are happy to offer medicine, pharmacy, and nursing continuing education. Here are the portal instructions on your screen. You will notice that this portal closes on May 15th at 11:59 Eastern Time. You must submit and complete the very short evaluation to receive your continuing education in those three areas by this time, or the portal closes and you will not be able to get continuing education. Also, the portal will not open until 2 o'clock Eastern Time. So hold on just a minute if you're trying to get it in real time, because it will not open until 2 o'clock Eastern Time. Also, Kentucky SOS is delighted to offer House Bill 1 CE credit for our providers. Here is the ID number for that through the Kentucky Board of Medical Licensure. Kentucky SOS encourages and promotes peer-to-peer learning, and this is just a wonderful example of that, and we're thankful to Clark Regional Medical Center for their education today. I will be sending out this presentation to the project leads. It will also be posted on the Kentucky SOS website. I encourage you to check that out. Give us about a week or so to get that posted, and any past educational events are posted on the website also. And also feel free to contact a Clark Regional Medical Center team for any of their resources, order sets, things like that, that you, or if you have questions or would like those resources, this is an excellent way for peer-to-peer learning. If you have, if you don't want to contact them directly, feel free to contact me, Emily Henderson. I'll put my email in the chat and I can contact them for you. There is a question in the chat box, Clark Regional Team. Can you see that, please, from Dr. Brenzel?
Yes, this is Ashley from the Emergency Department. We are dispensing Narcan to those at this point if they request it or they need it. that's our primary guide. But if they do have an overdose, then we are making sure that we offer that option. And lots of times you'll see family is the one who wants the medication. And luckily in our community, a lot of our patients are not alone. They have lots of caregivers with them or family members that really...
I see this a minute.
They have a lot of friends and family members who do come with them, and they want the medication so that they can help to rescue them if needed. So it's usually an overdose that does obtain the Narcan. However, we would allow anyone who requested it to obtain it. The same would go for the inpatient world. If somebody requested Narcan to go home or anything like that, we would take care of that with our partners for them.
Okay, are there other questions by phone or chat box today? Okay.